Hello, everyone. My name is Lizzie Stewart. We are pleased that you all could join us for this week's lecture in Volume 10 of our No Neuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. Before we start our lecture, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to No Neuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these here on our website and through APPCN. Here are the disclaimers for this series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Heidi Bender for today's lecture titled Creativity in Awake Craniotomy, a Patient-Centric Approach. Dr. Heidi Bender is a board-certified neuropsychologist and professor of neuropsychology at Weill Cornell Medicine in New York City. She specializes in evaluating and treating patients with neurological and cognitive disorders with expertise in epilepsy surgery evaluations, cognitive remediation, and supporting non-native English speakers and immigrants. Dr. Bender is deeply committed to reducing healthcare disparities and holds leadership roles in multiple professional organizations, including co-chair of the New York Neuropsychology Group's Bilingual Task Force and chair of the Hispanic Neuropsychological Society's Practice Committee. She has co-authored over 65 publications and has recently chaired the Interorganizational Practice Committee's Task Force on Test Security and Third-Party Observers. Please help me welcome Dr. Heidi Bender for her presentation in Awake Craniotomy.
Hello, everyone. I'm so happy to be here today. Thank you so much for having me. Just give me a moment to cue up my presentation and I am all yours. Okay. Give me 1 second.
The slides look good, Dr. Bender.
Great. I'm just sharing my audio and I will be off to the races. All right. Excellent. Well, hello, I'm Heidi Bender, professor of neuropsychology at Weill Cornell Medicine's Department of Neurological Surgery. And again, it is such a pleasure and a privilege to be here today for the No Neuropsychology didactic series. As mentioned, today's topic is creativity in awake craniotomy, a patient-centric approach, which will really discuss considerations working with unique or special patient populations, such as those who are bilingual or non-US born. Now, it's really my aim, most importantly, to discuss how neuropsychology can consider multiple patient-specific factors when developing the approach, implementation, and interpretation of direct electrical stimulation mapping studies. And the key that I'll be discussing is really to always place the patient at the center of every decision you make when preparing for awake craniotomies and also in real time in the OR. Now, before I go into detail, I just wanted to take a moment to ensure that we're all on the same page regarding the terminology that I'll be using in today's talk. So the application of direct electrical stimulation, or DES, for mapping of language or sensory or motor pathways can be done intra or extraoperatively. And it's really aimed at the identification and delineation of functionally eloquent cortices in and around a planned zone of excision during neurosurgical interventions. And paradigms should really be guided, really guided by what is believed to be the surgical target or within that surgical path, leaning heavily on activation patterns based on functional neuroanatomy. So today I'm mostly going to be focused on intraoperative cases followed by immediate surgical resection. Now, mapping of a surgical field is done really systematically, typically starting with the area of highest suspicion for eloquence based on preoperative MRI or fMRI. And intraoperative mappings are often informed by extraoperative mappings. However, beyond the discrete cortical targets, we really want to think about not just that one area that's believed to be, in the surgical plan for excision, but also hodological nodes, which really participate in the network beyond that cortical epicenter and really support more translobar functions. Endpoints of a mapping when applying stimulation are really considered to be maximal stimulation, meaning you can't stim anymore, without interference of functioning, an appearance of after discharge on ECOG, or if there's symptoms such as speech arrest or any sort of what we will call HIT, as you'll hear in a moment. So the overwhelming majority of my presentation will be discussing my own patient-specific paradigms that I've created in response to my patients' needs. Now, as you'll see, I've made additions and enhancements and modifications of existing paradigms that are well validated and highly studied. So the content, the themes of what I'll be talking about, it's really steeped in the literature. However, my modifications are what's novel and untested and unvalidated. So I really want you to think about that. Don't be heavily reliant on my data per se for your own decision making. Really, what I'm encouraging you to do with this talk is to get lost in the literature and come up with your own connections while simultaneously acknowledging the range and the scope of the confounds that each of your decisions may confer. And it's really key to have an open discussion with the surgeon so they too are well aware in advance that novel paradigms will be used and the data that's garnered will be of questionable value. Also, having that same conversation with the patients themselves so they too can have informed consent. And lastly, for anyone who's a trainee or really at any stage in your career, developing these tasks required a lot of supervision for me. So inter and intra-disciplinary collaboration is key. Be humble at identifying the gaps in your own knowledge and don't be afraid to ask for help. So as I mentioned earlier, the base of my mapping, it's really not magic. It's not anything unlike what others are using, I'm sure nationwide, resting heavily on the shoulders of mapping giants like Dr. Marla Hamburger, who's at my sister institution, Columbia University, or Dr. David Sapsovitz at Mayo Clinic. A lot of these targets, they're really dependent on what neuroanatomical target are being tested or in that surgical path or part of the surgical plan. But my battery typically includes oral motor dexterity, like having the patients go ma, 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 pa, 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 making sure that they can use their tongue, lips, and mouth. Classic verbal fluency, which I think people really most associate with mapping procedures, days of the week, months of the year, counting are among the few. Confrontation naming items, showing patients a picture and having them name the object. Receptive language, making sure that they're understanding by giving them commands or doing an auditory verbal naming test. What a king wears on his head is, and then the patient would have to provide that answer. Having them repeat single words and brief sentences, having them read both single words and also fill-ins to kind of assess their reading comprehension. And lastly, we often, both not always, try to assess sentence syntax and structure. So the audio on these first few slides are a little bit low. So what I'm going to do is rather than play them, I'm going to just let you know what's being said. And then later you'll be hearing a lot of OR clips as though you were with me during these cases, okay? So again, for those of you who might not perform a lot of functional mappings on a regular basis, it's really important to hear how subtle a change in language can be during DES. So this is a clip, would have been, of a US-born, US-educated, native English-speaking epilepsy patient. And so I have him say, I like ice cream, and he very readily repeats, I like ice cream. The man had a blue car. The man had a blue car. Very easy, very clear. That would be called a cleared site. However, when you have some sort of alteration in the function upon stimulation, we call that a hit. So a hit can be very clear in some cases with patients, as you'll hear in a moment. And sometimes they're not as clear, as we'll hear in a couple of slides. So in this one, the patient was able to count very fluently 14, 15, and they'll stop, they'll have speech arrest, and then they'll go right back 16, 17, 18 when the stimulation was removed. So that was very clear, and you'll hear me say very clearly in the video, hit, and that's letting the surgeon know, okay, here's an area we likely want to avoid because it's key for speech production. Now, you can imagine if you've ever worked with someone who's non-native English speaking, which I'm sure is everybody here, but if there's a patient who's been opted to test in English or any language that's not their native language, sometimes a pause in their speech or some sort of word finding difficulty might not necessarily be due to the stimulation causing the speech arrest or the speech delay or the paraphasia. It might be because that's the patient's baseline on that item in that moment. It might take them an extra second to remember a word. And as a result, it's very easy to make a misattribution. So this is a cleared site in a non-native English speaker. She counts fully 1 to 10 without any alteration or interruption upon stimulation. Now we have a questionable one that I would play, and this one I think is very interesting. I do wish you could hear it, but the patient's baseline for counting, it was errorless when we tested her pre-operatively because we always make sure that we check on all of our paradigms and we get used to the cadence of our patient's speech outside of the OR. There were occasional hesitations, though, very slightly, even at baseline in an outpatient setting. So there was some concern raised, by myself and my team for some misattribution. So as you would hear, the patient counts errorlessly and fluently from 1 to 16. And then before she got to 17, she said 15, 16, 17, 17, 18, 19. Was that pause the result of electrical stimulation or the patient's English as a second language status being tested in not their native language? And so what we do in these cases is we repeat items in that same area. We keep stimulating that same area again and again in order to replicate the findings. And we may use counting, we may use something else because we obviously don't want them making the same error over and over again. But we will repeat different items within that same domain, in that same area, to make sure the hits are replicatable and that the underlying cortices are either clear or impacted. And we're very mindful, though, to keep the mappings as brief as we can because lengthier mapping times result in increased risk of infection, increased risk of seizure on the table, patient fatigue. So it's always striking a balance. So this would be a hit for a non-native English speaker. And here the patient said very clearly, and we replicated it multiple times, 14, 15, 17, 17, 17, 18. So that was very clear and again, replicatable. So given these clear challenges when mapping patients in their non-native language, we have to pay very close attention when developing and interpreting a language mapping paradigm. And so that's where the kind of the creativity comes in, because sometimes you can't think about your core battery. You kind of have to throw your core battery out the window a little bit, not have such a Eurocentric point of view, have a more broader, inclusive worldview, as we'll talk about quite a bit, in order to modify things so that they are the best fit for your patients. So in terms of my approach, I of course first review the patient's neurodiagnostics and fMRI if it's available, awesome, and then consult with the surgeon about their surgical plan, what is not only the zone of excision that's planned, but also their approach to get to that zone, because that's also very key in making sure that we map in those areas. And then we meet with the patient and their family for a very extensive pre-mapping visit. And, some folks have said to me, like, oh, wow, you really spend a lot of time outside of the OR with these patients. And we do. To me, it's really a vital touch point in ensuring a successful procedure, because it helps us create this very tailored patient-centric approach. And we do the same thing with, individuals who are US born and English speaking and US educated and who have, no special considerations. We do the same types of things, but we may conceptualize their case a little bit different. So during the visit, we'll discuss, again, regardless of who your patient is, we talk about their ability to fully engage in the mapping process. Considerations like mood or their emotional baseline, sociocultural and linguistic factors, if they have a unique frame of reference or a unique worldview that we need to consider, or if there are any physical factors which may interfere with mapping or DES. So in the cases that I'll be discussing with you later today, I'll be focusing mainly on the two bullets, the one that's red and the one that's yellow, sociocultural and linguistic factors, as well as the need to consider a patient's unique frame of reference when prepping a paradigm for their procedure. So now that I've kind of introduced this framework, which I always call meeting patients where they are, I want to walk you through my thought process of this first case. So as I mentioned earlier, I first thoroughly review the patient's medical history, including neurodiagnostics. This specific patient had a 5-year history of epilepsy prior to presenting for a pre-surgical evaluation. She had focal onset aware seizures, which occasionally would generalize into something more like a generalized tonic-clonic event or some sort of more generalized convulsion. Most commonly, though, her semiology, or what the symptoms that we would see, were leg and arm numbness she would experience, some speech arrest, difficulty hearing, and sometimes she would hear a buzzing or a beeping noise in her right ear. Now, her seizures were happening multiple times a day, sometimes for about 30 seconds. They weren't very long seizures, but what was really, really getting to this patient was it wasn't really the event itself, particularly it was if it was more somatosensory, like the numbness, or she would hear the beeping. What would really be so impairing is she would have a 15 to 20 minute post-ictal period where it was very much a struggle for her to return to her functional baseline, her energy level, her fitness level. She found it hard to walk, her speech level. So even though the events maybe took up 2 minutes of her day, recovering for them took up to an hour. She was on multiple anti-epileptic drugs. She had several really severe episodes of seizures that went on longer than 5 minutes. So she had status epilepticus. Now, multiple EEGs that she had over the years suggested left temporal spikes in seizure onset, as well as like left frontotemporal slowing, so that there was some involvement. It wasn't necessarily the seizure generator, but perhaps involved in some way. So the patient had a 3T MRI and also a 7T MRI, which was used mainly for research. And it appeared to be non-lesional on both the 3T and 7T study. No significant findings, so again, considered to be non-lesional, though a PET scan did reveal some hypometabolism in the left anterior and medial temporal lobes. Medically, the only other factors to kind of bear in mind, some of the episodes of status were in the context of binge drinking and also uncontrolled type 2 diabetes. And now that we've considered the patient's neuromedical factors, I really want to discuss how language and sociocultural factors were simultaneously considered in her plan. So this patient who I just discussed, she is bilingual and Thai speaking, and she spoke a pretty unusual dialect, which had many regionalisms that were very specific to her own hometown. She began learning English as a youngster in school, but didn't really speak it daily on a very regular basis until she immigrated to the US many, many decades ago. Now, it was very important for this patient specifically to maintain a high level of Thai fluency because she's the caregiver of a monolingual Thai speaking family member who had a terminal illness. So she kept saying to us, like, if she couldn't continue to fluently communicate in Thai, she could no longer maintain that effective caregiver role for her family member and also communicate with them in their last days. So both of which were understandably vital for her. So I came to learn when sort of researching the Thai language that it's a tonal language. It's highly tonal. And there are 5 different tones: mid, low, falling, high, and rising. And each tone variation changes word meanings. And other languages where tonality, just incidentally for your own knowledge, other languages where tonality during DES should be strongly considered are Mandarin, Cantonese, Vietnamese, Punjabi, several dialects spoken in Africa, among many others. So, in addition to kind of considering any neuroanatomical differences secondary to tone, which I consulted the literature very, very extensively, um, I also looked up the literature, which, I did already know, but I like to keep abreast of the literature. I encourage you to do the same. Looking at multilingual individuals and really underscoring the fact that multilingual individuals may possess more diffuse, robust language organization than their monolingual peers. And this is something that should also be thoughtfully considered when you're considering potential areas of eloquence during DES. Now, beyond the language characteristics itself, when you're coming up with mapping paradigms for, unique patients, really make sure that you think about the item's content, its salience, and its applicability to your patients. And that's a very important guidepost. So we've all heard, on the mental status exams, no ifs, ands, or buts, and you have a patient repeat it. However, this phrase doesn't really make sense to people worldwide in the same way that it might to an English speaker. So we try to avoid, kind of culture laden or education dependent statements or phrases or items to the extent that we're able. So, to truly meet patients where they are, really really think about variables that are highly specific and unique to your patients, it's important to think about and really discuss their own frame of reference, having really frank conversations with them about what they can anticipate during the mapping, what can they anticipate after the mapping in terms of deficits. Do they have any non-medical reservations that might be essential in voicing prior to the mapping itself? What are their priorities? Do they hope to be seizure free? Do they hope to have a meaningful reduction in seizures? Do they hope to have zero deficits neurocognitively, zero neurocognitive morbidity whatsoever? Are they anticipating something? What are their hopes? What are their fears? These are very important conversations to have, and unfortunately, ones that I think are sometimes very much ignored. So, in the case that I just introduced, that patient's frame of reference is that no degree of deficit in Thai would be tolerable to her. She requires, we know, based on what she told us, a high degree of English fluency as well for her work and her social relationships, her day-to-day life, but Thai was equally as critical. So the decision was made to complete the procedure in both languages. And that was something that we discussed very extensively with the surgeon as well, due to that increased operative time. Now, another issue with this patient that I think none of us were really anticipating as a barrier was she's very deeply religious. And as a devout Buddhist, she was concerned about altering the divine plan for her life. karma, and whether or not this would be perceived as a lack of faith or trust in like a higher being. And she really questioned that by pursuing epilepsy surgery to reduce her seizure burden and seeking medical treatment, was that really discordant with her cultural and religious beliefs. And that level of indecision and anxiety was super high and very significant. So we actually together sought consultation with a religious leader in her community just to kind of cultivate a greater sense of peace preoperatively. Also, in an effort to most holistically serve this patient's needs, several modifications to my standard battery were needed to reduce that risk of postoperative morbidity. And obviously, we needed an interpreter as well. Now, we couldn't find an interpreter who spoke the same dialect as this patient within the hospital. So we had to use an interpreter who spoke Central Thai and then discuss the similarities and differences between this dialect and Central Thai. And what are the potential confounds? We discuss those closely with the surgeon and the patient as well. And as I said, prolonging this mapping time, we really had to, by doing it in both languages, we really had to speak not only with the surgeon, but with the patient about the greater number of risks for every minute that we were kind of mapping. And she was very, very aware of this. She was very aware that, what the consequences could be if she did not prolong the procedure, and also if she did, and really making sure that we preserved her tie no matter what. So in order to do this, I developed a novel task, which was used to evaluate the production and perception of pitch changes during stimulation in and around Heschel's gyrus. And you'll see why in just a sec. So following that pre-mapping visit, we did a bedside extraoperative language mapping. So not in the OR, but at bedside, really to better examine the eloquence of the cortex within the patient's seizure onset zone and their suspected seizure network. And really during that time, we were able to administer a range of standard tasks, and anything that the patient had any sort of hesitancy, any issues with comprehension, with prolonged latency to respond, as I mentioned, paraphasias, difficulties with salience. Anytime she said, I don't know what that is, I don't understand what that means, we took out the item and it never appeared again. We wanted to make sure that we did that in pre-mapping. We also did that in extra-operative mapping. And we worked very closely with our interpreter throughout all phases of this to ensure the smoothest experience possible in the OR. So the results of this extra-operative DES suggested functional changes, seizures, and after discharges in the patient's anterior temporal lobe, as well as the lateral temporal and superior temporal gyral medial cortices, extending all the way to Heschel's gyrus. Now, given that this anticipated surgical plan included Heschel's gyrus, it was really clear to us that we needed to really assess and prioritize this aspect of functionality in the OR during the intraoperative mapping, because Heschel's gyrus has been described throughout the literature as necessary for the maintenance of pitch perception in tonal languages such as Thai. So we knew that this area was extra critical. So I don't speak any tonal languages, so I tried to conceptualize it for myself using an English language equivalent, and I'm going to do that for you right now. So the word present. I was present for today's lecture versus my name is Heidi Bender, and I'm going to present my talk to you for no neuropsychology. So it's the same word, but the stress lends itself to a very different meaning. So understanding conceptually about tone, integrating what I could from the extant literature and sort of using that as a map. And then I worked very closely with a Thai speaking teacher and also as an interpreter. And I use them as my guide. So I had my own conceptualization as my map, and then I sought consultation as my guide. And I developed a novel paradigm to grossly assess, and grossly being the operative word here, pitch, production, and perception in Thai in the OR. So I'll be showing you how that was done. So my thanks and my gratitude to this English-speaking Thai teacher whose voice you'll hear in just a second, and also the interpreter who worked closely with me in the OR to administer. So you'll hear that the words for horse and the words for dog are very much the same. In Thai, I'm going to play them both.
ม้าหมา
And so as you can hear, the word is the same, but the stress is quite different. And that conveys obviously a different meaning. So first what we did was I asked the patient to provide the word for each picture one at a time. So first I showed her the picture of horse, had her say the word, then the picture of dog, had her say the word, and it was like a confrontation naming paradigm. And we had the interpreter pay very close attention to the pitch and the tone of the speech production during stimulation. And that was sort of the goal of assessing how we could assess this patient's pitch production during stimulation in Thai. Now, we also had to make sure that the patient had adequate pitch perception. So during this administration, she would be shown both pictures side by side, and the interpreter would say one of the words,
ม้า
and the patient would then have to correctly select, in this case, the horse, the picture that goes with that word. So I have a couple of more examples, but they're very much the same. And we had, I believe, 15 different examples that we cycled through during stimulation. Here's another one. The words rice and white sound quite similar with a difference in tone.
ข้าว ขาว
Okay, and I'll show you one more. Tiger and shirt.
เสือ เสื้อ
So it might be very subtle to the ear, but certainly not subtle to someone who is a Thai speaker and someone who needs so desperately to connect and communicate with their loved one. So armed with this sort of full complement of information regarding the patient's structural and functional neuroanatomy via their neurodiagnostic data points, the intra and extra operative mapping results, the surgeon made a very highly tailored surgical plan. Remember what I said earlier about you don't want to spend too long mapping or too long doing any one thing in the OR. Unfortunately, about 10 minutes before we were done the latter portion of the mapping, the patient had a seizure on the table and she did not return to her functional baseline. So the remainder of the mapping was aborted, but thankfully we were able to get the overwhelming majority of information that the surgeon needed in order to proceed safely. So this patient is unfortunately not seizure-free, but there has been a very meaningful reduction in her seizure frequency and seizure severity post-operatively, which she is absolutely thrilled about. Equally as importantly, functionally, she has no post-operative language deficits in either English or Thai. And in fact, her husband, upon follow-up, said that she had improved English language ability. So I don't know how that's possible, but that's great news. There was absolutely no noticeable changes in her ability to communicate in Thai and a slight improvement in English. So the patient was very pleased with all aspects of the surgical intervention, and most importantly, from her medical care, she's not had another episode of status epilepticus post-operatively, so not one of these very prolonged and severe seizures. She's not had one of those in years, which is great. So the second case that I'm going to present to you is of a young woman. She was in her usual state of good neurological health, and she had a prolonged witness seizure during sleep. She was taken to the ED, and neuroimaging revealed a large left frontal mass. So the surgical plan included resection of that mass within the left inferior frontal gyrus, extending posteriorly into the anterior aspect of the left precentral gyrus. And so we tested this patient. We got to know her very, very well. We did baseline preoperative neuropsych testing, and it really did show some mild confrontation naming difficulties in English and in her native Polish. And we weren't really certain as to whether or not these deficits that she showed on neuropsych testing were a function of linguistic, cultural, or educational differences, or if they were secondary to the tumor, because, obviously we didn't test her 5 years prior before, the tumor existed. But what I think was really telling is the patient herself said that she was having mild word finding issues and some inattention for several months prior to the seizure. But she was a very new mom, and she attributed these changes to being newly postpartum and sleep deprived, and didn't really attribute them to anything else, which is why she didn't actively seek medical care prior to the seizure. Also very important to consider that this particular patient had a fairly significant history of baseline psychiatric issues, depression, for which she was receiving pharmacotherapy, anxiety, panic attacks, which happened fairly regularly, and also of a history of eating disorder. So this patient expressed considerable concern about her level of anxiety during the awake procedure, really worried that she was going to shut down emotionally, with a trigger being if she felt like she wasn't performing well enough. So we kept trying to explain to her, like, look, there are going to be times where we're going to stop that functionality with the stimulation, and you're not going to be able to perform well. And that's us, not you. But she said she was really worried about that being a trigger, and also the understandably heightened emotions of her very recent health issues. So she had her seizure on a Saturday. We met with her on a Tuesday, on a Wednesday, and by Thursday she was on the table. So this is all just a whirlwind. And she was also concerned, and this was something that we passed on to the team, the surgical team and the nursing team, that they didn't know, but the patient was concerned that any post-operative nausea or dietary limitations post-operatively would cause her eating disorder to reemerge. So we wanted to make sure that everybody was paying really close attention to that. So the second case really highlights the need for a patient-centric thinking when conceptualizing mapping procedures, because the patient, self-described as being bilingual in English and Polish, really considered herself to be English dominant. This is a language she speaks daily with her husband, her son, her neighbors, her friends, and so on. She rarely uses Polish in her day-to-day life, except when she is playing music. And she is a professional musician, and she learned this skill very early in life, from when she was 3, and really kind of all the way through. She has a master's in music from an international university, and she was a professional violinist. And she felt like in order to continue with her professional career in music, she still needed to preserve the ability to think in her first language, Polish, because that is what she thought in when she played the violin. And she felt that even though she was not very regularly using Polish in day-to-day life, this was critical to her sort of future. And as a result, loss of Polish was an unacceptable post-surgical morbidity. So we really had to accommodate this patient in terms of her anxiety. And so one of the ways that we did that, not just linguistically, but in terms of, more holistically, she spoke with her treating therapist to get some strategies that have worked with her in the past. And the therapist worked with me in order to help educate me so I can implement those same strategies in the OR if I needed, particularly if the patient experienced symptoms of panic. Also, in terms of her unique frame of reference, the presence of fine motor deficits for this patient, even very subtle ones, were absolutely unacceptable given her occupation as a professional musician. It was just a line that she was not willing to cross. And she considered her ability to play music critical not only for her ability to work, but for her mental health, for her well-being. And so that was something to really be respected and honored as well. So for her, fine motor control and Polish language were key and core considerations, as well as, she told us, working memory. And she felt that working memory was key when performing at a high professional level, because you not only have to hold music in mind as you're playing it in real time, you also have to think ahead and anticipate several measures ahead of the music in order to play in a high-level orchestra, as she did. So this patient's care really required consideration of each of these factors listed. And in order to really meet her needs as to where she was in the context of the recent diagnosis of a tumor and the upcoming resection. So to recap, for this patient, meeting the patient where they are required consideration of her psychiatric factors, linguistic, cultural, and educational confounds, unique frame of reference, and also this additional concern regarding physical factors, which, if ignored, could limit her ability to work post-operatively. So in an effort to best address this patient's specific concerns during the mapping, we first completed, and all of this was baselined in a pre-mapping visit, of course, but in the OR, we completed English language metrics, much like the list that I showed you before, in order to ensure that there was a clear window to the tumor that did not include eloquent cortex. So you can think of it like a spiral. Now, once this field was established, we worked with a Polish-speaking interpreter who was in the OR to ensure that that field was also clear when speaking Polish. And we anticipated that it would be. Neither is really a tonal language, but obviously we wanted to double check. So we made sure that window stayed the same and it didn't narrow any. And then once that surgical window was established in both languages, we reevaluated again in the context of the patient's ability to play music. So first, we completed a music-based working memory task, which you'll see in a moment. Again, to make sure that the patient would not only be able to read the music, but also to think ahead. And lastly, we permitted her to play her violin in the OR during intermittent stimulation to ensure she continued to be able to do so should any and all structures in that remaining surgical field be resected. So before we watch, just please know you will be able to hear her voice. You will be able to see parts of this patient. She did sign consent for this to be used for educational purposes. So the patient, again, she educated me. I didn't know as a non-professional musician that you really have to read ahead for sheet music when you're playing in a high-level orchestra. And this requires many neurocognitive processes, particularly frontal lobe functioning. Now, given that the surgical approach might encroach on the FAT, the frontal aslant tract, which is a white matter tract that connects supplemental motor complex and lateral superior frontal gyrus to the inferior frontal gyrus, it was important for me to incorporate a paradigm to test functionality in this area. Now, typically, if we know that the frontal aslant tract is in some way involved in the surgery, we'll test it through a digit span, like a digits forward type task. But in an effort to really conduct a tailored mapping with maximal applicability for this particular patient's own life, we use a task where there are progressively complex musical scales that are played. And there are two played, and the patient will have to determine if they're the same or they're different. Now, this task was developed as part of the NeuroMapper program developed by Dr. David Sapsovitz, who's currently at Mayo Clinic in Jacksonville, Florida. Now, as you'll hear in a second, the patient made an error on the first trial, but she completed the following 10 without error, and you'll even see she smiles as she's doing it. All right, here you go. So she had to say if they were same or different.
They're different?
And she made an error.
That's incorrect. Let's try another. Stay with me, okay? Doing great. Same or different? Correct.
We'll just watch a couple more.
Different. Very good. Different?
And so there's really no true to life proxy for orchestral music in the OR, but I think this was a pretty creative approach for assessing at least the working memory music related abilities for this particular patient. So after both English and Polish language testing, and you can all still see my screen, correct? I'm gonna go with yes. So after both English and Polish language was tested and that corridor was defined, we also allowed this patient to play their violin in order to determine whether or not any area within that surgical path would impact or change her ability to play the violin. And I want you to really pay attention to the hand that's holding the bow and watch it during the DES. Now, obviously, you won't be able to see the stimulation, but you'll notice at a point that you'll see that there's an area that's critical to the patient's ability to continue to play, which helped us further refine that surgical path or zone of excision. And so here we go. I'm going to play it. And she's playing Twinkle, Twinkle, Little Star because it reminds her of her son.
Okay. Good job.
Great job.
You did it. Yes.
And you can see that she dropped the bow during stimulation, which again, had that area just been removed, she would not have had the control in order to continue holding her bow. So it was a very, very important step for this patient's care. Much of the tumor in the patient's left inferior frontal gyrus, which again extended posteriorly to the anterior aspect of the left precentral gyrus, was removed at the time of surgery. And I'll tell you how she did. So there was some residual tumor that couldn't be removed due to eloquent cortex. She ended up having the pathology, the final path showed left frontal mutant oligodendroglioma. And so she received radiation and chemotherapy for treatment. Now, initially, she had a very rocky post-operative course that was complicated by frequent seizures. She had hydrocephalus. She had aphasia. It was a really rough go for a couple of days, to be sure. However, after the swelling resolved and time had passed, she feels as though she has no cognitive issues, with the exception, Polish is largely unchanged, but she has very, very mild confrontation naming deficits, and she uses the word only when pushed or when she's fatigued. So that was only in English and with very low frequency words, so she was very pleased. Most importantly, she retained the ability to play the violin and continues to do so daily. She expressed great just unbelievable gratitude for the highly specific care she received. She felt really well cared for, and she said she felt like a human being, which, I mean, what better gift can we give to our patients? And also she felt heard. And that's something that I encourage you to walk away with as well. So today I've really presented two cases that I hope encourage you as, at whatever level of career you're in to really think about mappings or any procedure by taking a holistic and inclusive lens, employ a biopsychosocial approach that's tailored to reflect each patient's unique life experiences, and really develop this paradigm, but also this relationship in partnership with the patient. It can't be your own perception as a neuropsychologist, even if you're well intended about what you think a patient may want to do or what they should want to do. It's not your call. And really need to think about the potential post-operative impairments and contextualize it in terms of the patient's functioning in their lives. And again, not what your own perception of this should be. And so really thinking flexibly and creatively about a patient's care during DES, think about how the patient can be an active partner, not just in the pre-mapping visit and not just in the lead up, but in their actual surgery. So we do this again by forming that relationship through extensive interviewing, rehearsal, psychoeducation, encouragement, and rapport building, which then is key when you are in the OR and it is, again, a really, really tense environment by any standard. I always say to the patient, and I've never, thank goodness to date, have never not kept my word. I say to the patient, I'm going to be by your side from the minute you wake up into the minute you go back to sleep. And then I'm their point person from the skin incision to suture. And I'm able to voice their concerns to the surgical team because, again, the way they're draped, the neuropsychologist is very much at the forefront of what they see. And I think this is oftentimes very helpful in allaying patients' fears, making sure that they know that there's an intermediary between them and the surgeon, because oftentimes the patient can't see the surgeon during the mapping procedure, just given positioning. So we at Weill Cornell Medicine Department of Neurological Surgery, we provide a lot of continuity of care post-operatively. We provide support following discharge, integrated approach to cognitive remediation and psychotherapy as needed. I'm not saying that that's the case in all settings, but it's very nice to kind of continue that relationship with the patient. The one who played the violin, we're actually still seeing her for treatment. My colleague is, and I've seen her post-operatively as well. So to wrap up, I just want to make sure that this talk has good generalizability to as many listeners as possible. Not everybody is going to, be in the OR right away or work with these kind of unique situations and patient populations. So I just wanted to close with a few touchstones for not only these specific cases, but other complex, multidimensional ones with bilingual or non-native English speakers, individuals who are non-US born or non-US educated. And this slide, which really takes you through this very nonlinear considerations when working with special patient populations about history, different considerations, different ways to interpret data, and different challenges collecting them. This is adapted from a paper that we published in World Neurosurgery in 2023, and it really emphasizes the flow of what needs to be done and how everything is sort of interconnected with, again, keeping the patient at the fore and really continuing to review any potential confounds that may limit the reliability and validity of your findings. And so with that, I want to take a minute to thank the neurosurgeons who I work with, who really give me the freedom of creativity, and also to the patients that were discussed today, among others, for giving me their trust during this very difficult time in their lives, and also to you, of course, for your time and attention.
Thank you very much, Dr. Bender. This was an excellent presentation. We do have a couple of questions that we're hoping you can answer just to expand on your presentation already. So one of the guests asked about tonality, specifically how tonality is a part of their native language. And they were interested to know if consideration was given for any synonyms for word used, especially when those differences might be exceptionally subtle to pick up.
Understood. And so that's a great question. And so since I don't speak some of these languages, like for this example, Thai, since that's not something that I have any background in whatsoever, we spoke with the interpreter to make sure that we are not picking words that were, too similar or synonyms. We were very, very careful in the items that we selected. So we basically went to our Thai and English speaking teacher gave us a list of probably 30 or 40 different options. And then we worked with the interpreter to select the best choices that would be the most sort of impactful in Thai. So that way we can really make sure that we knew the data that we were extracting were as close to real as we could. That was a great question.
Thank you. And then this is just more broad, but could you maybe give us some tips or just some ideas on how we can apply these findings to a more broad approach? I know for myself, we don't see a lot of Thai-speaking patients here, but we do see quite a few Latin American and Spanish monolingual folks. So would some of your findings, specifically some of your patient suggestions, do you think those would translate to other languages or yeah.
Absolutely, without a doubt. That's my whole point, my whole goal of this talk, because it's very unlikely that you're going to end up with a concert violinist or somebody who speaks a very unique dialect of Thai in your practices. There is so much applicability and generalizability from keeping the patient at the forefront and meeting patients where they are. And even again, if you're only working with US born monolingual English speaking US educated patients, you can still keep the patients at the forefront of every decision that you make by extracting a ton of information from your intake, really refining that information during your pre-mapping visit, making sure that you're picking the most appropriate stimuli and that you're doing everything you can for that specific patient in that very specific setting for that slice of time. So absolutely, if you take nothing else away from today's talk, take that away.
Thank you very much. I think that's something that I think we can all strive towards. And our next question actually kind of dealt a little bit with some of those barriers to striving towards it. A lot of times in larger academic medical centers or just any practice in general, it can be difficult to spend as much time as we know that we need with these patients. Have you found any creative workarounds or ways to encourage our presence on the team or encourage our administrators to allow us to have a little bit more time with those patients so that we can have a little bit more of those impactful decisions on the team?
It's also a great question. It's for those of you who know me, I am typically not someone who toots my own horn, but you toot away. When you have a win, when you have a success, when a patient is telling you that you have done everything that in your power to make them feel heard and make them feel like a human being, make sure your administrators know that. Make sure your surgeons know that. Make sure everybody knows that. Make sure that the wins are heard and people know why. Make them know that, okay, this patient is now able to continue being a concert violinist because you took an extra 30 minutes during a pre-mapping visit, or you took an extra 20 minutes in the OR. These types of presentations, also making people aware of the wins on a more global level. Write them up, show people the presentation, show them the manuscripts. To me, that is definitely a way. It's not a workaround, I wish there were, but it can certainly make sure that people know you have value. We all know that here, but we need to make sure everybody knows it.
Great. Thank you very much, Dr. Bender. I think those were all of our questions. So thank you very much for your time, and thank you for everyone who attended. Please join us again in just a couple of weeks on December 9th. That will be our next talk entitled At the Heart of It, the Neuropsychology of Congenital Heart Disease with Dr. Bruna Schneider. We look forward to seeing you all again in just a couple of weeks, and have a happy Thanksgiving if you all celebrate. Thank you very much.